Hello everyone, today we're going to be learning about acute pancreatitis. As a summary, acute pancreatitis is a condition which is an inflammation of the pancreas. So quickly going over the anatomy of the pancreas, we have the pancreas is split into three parts: the head of the pancreas, which corresponds with the duodenum, the body of the pancreas, and then the tail of the pancreas, which attaches to the spleen. The image above can show you the anatomy, the vessels such as the splenic artery, and all of the anatomy of the pancreas. The pancreatic islet is made up of three cells, which is the alpha, beta, and the exocrine acinus. The pancreas has two functions. The first is endocrine, so the beta cells in the islets of Langerhans of the pancreas produce and release insulin, which is important in the uptake of glucose from the blood and helps to maintain and regulate your blood sugar levels. A condition that this is relevant with is diabetes mellitus. It also has exocrine functions. The pancreas is important for producing digestive enzymes, particularly amylase, proteases, and lipases, which break down fat and proteins. Okay, so there's a very useful mnemonic called I get smashed, where on the left you can see, which shows the most common causes of acute pancreatitis. The three most common being idiopathic, gallstones, and ethanol. Ethanol meaning alcohols. So a patient who drinks a lot of alcohol, is obese, or has been exposed to trauma, has gallstones, mumps, steroids, scorpion stings, autoimmune, hyperlipidemia or hypercalcemia. He also has had an ERCP procedure, or any drugs such as methicillin in particular are more susceptible to developing acute pancreatitis. Of key note to remember is hypercalcemia, so high levels of calcium causes acute pancreatitis, but hypocalcemia, which is low levels of calcium, is an indicator of the severity of acute pancreatitis, so whether it is mild, moderate, or severe pancreatitis. This and other indicators include the Glasgow-Imrie criteria. So you can see on the right the mnemonic pancreas, so a PaO2 of less than 8, age over 55, neutrophils, hypocalcemia, a urea of over 16, enzymes, high AST and LDH, low albumin, and high sugars. Having three or more of these criteria would indicate that the patient has severe pancreatitis and requires hospital admission. Upon presentation, the acute pancreatitis will typically present as acute epigastric pain that may radiate to the back and is particularly severe after having a fatty meal. They may also be tachycardic, have an upset stomach, unwanted weight loss, and have a fever. Remember, it's an inflammation of the pancreas, so they may be febrile. Other symptoms such as diarrhea and dehydration and bleeding. Two major clinical signs that you want to look out for is Cullen sign, which is a discoloration and bruising of the umbilicus caused by retroperitoneal bleeding, as well as Gray Turner sign, which is a bruising of the left and right loin flanks, are characteristic of acute pancreatitis. To investigate, we would first look at serum amylase and serum lipase levels, which would be raised by at least 3 times the regular amount, so it'd be in the thousands. Serum lipase, just make sure you note, is typically more sensitive and more specific than amylase, so it's a better indicator of acute pancreatitis. The gold standard imaging will be ultrasound of the abdomen, where we can use to see if there's any inflammation around the area of the pancreas, and if there's still diagnostic uncertainty after doing an ultrasound, we can also take a CT scan. To manage acute pancreatitis, we can use conservative medical and surgical interventions. So conservatively, fatty foods make acute pancreatitis worse. So you want to have a low fat diet. You want to cease smoking and other factors that may worsen, such as alcohol. So alcohol cessation and smoking cessation would be advised. Medically, patients with acute pancreatitis will be severely dehydrated, so we want to give aggressive fluid resuscitation to the patient to hydrate the patient. They want to be given analgesia for pain of the abdomen. Typically, we would give phenthizidine and tramadol or fentanyl 20 to 50 micrograms IV. Morphine, please note, is contraindicated because it causes the sphincter of Oddi to contract, and we don't want that. The patient needs to be given nutritional support, so that means making the patient kneel by mouth, using an NG2 for early feeding if it's tolerated. Enteric feeding can be used for moderately severe pancreatitis, and nasojejunal feeding if nasogastric feeding is untolerated. We also want to give antibiotics if there's infective pancreatitis or cholangitis to reduce signs of inflammation. And now surgically, ERCP, which is endoscopic retrograde cholangiopancreatography, as well as being diagnostics, which can be used to diagnose pancreatitis. It can also have therapeutic effects, so it can be used to remove gallstones or any obstructions in the bile ducts that can be, or in the biliary tree, which can be causing the acute pancreatitis. If the patient also has gallstone pancreatitis, we can do a cholecystectomy open or laparoscopic to remove the gallstones. And here finally are some of the complications: septicemia, peritonitis, ascites, and pancreatic pseudocysts, which can or complications of acute pancreatitis. That was a very quick overview of acute pancreatitis. If you have any questions, please comment down in the comment section below. Thank you so much.